now. Great. So the objectives of the webinar today. Firstly, to share information on how social behavior change approaches can be used to improve nutrition and health outcomes in both humanitarian and development contexts. And secondly, to share information on how the Technical Rapid Response Team, the Tech Rrt, can provide technical support to social behavior change. And we're going to be going into much more detail on both those fronts. So, but before we do that, I would like to introduce the 4 presenters we have today. So firstly, myself, my name is Ben Allen, and I'm the Deputy Program Director of the Technical Rapid Response Team. And we're very lucky today to have Sona. Sona, you're on mute, I believe.
Hi, Ben. Can you hear me now? Okay. Hello, everyone. I'm Sona Sharma. I am the SBC advisor with the Tech Rrt.
Great. And we have Ravi.
Hi, everyone. My name is Ravi Menon. I'm the Indonesia Country Director for the Global Alliance for Improved Nutrition, or GAIN.
Great. Thanks, Ravi. Very pleased to have you here. And Mohini?
Hello, everyone. I'm Mohini Venkatesh, and I'm an advisor on school health and nutrition at Save the Children US, and I support projects in Asia and Africa and work globally as well. Pleased to be here on this webinar.
Great. We're very happy to have you all. Thanks for joining us. Okay, so I'm now going to go over today's webinar. So introductions and objectives we have just covered. We're going to have a brief overview of the Technical Rapid Response Team. Now, I am sure there are a number of you on the line who already know what the Tech Rrt do, so you can take a few minutes to do something else if you so desire. And then after that, Sona is going to take over, and she is going to take us through SBC theory, SBC in emergencies, and certain SBC processes. So she's going to cover the more theoretical underpinnings of social behavior change programming before we have case studies from Indonesia that will be presented by Ravi, and a second case study from Bangladesh that will be presented by Mohini. And after that, we will be preserving so each of the case studies will be about 15 minutes, and the question and answer session will take place straight after that. And we'll have at least 20 minutes for you to ask, or for us, for the panel to answer questions. The questions should be put into the chat box at any moment throughout the webinar. So whenever a question comes to mind, please put it there. And we hope we'll have so many that we won't be able to answer them all. So we will be selecting those which the panel wish to respond to. And if there really is an oversubscription of questions that we can fit into that session, then we will look into how we can respond to those following the webinar. And finally, as well, before the Q&A, in fact, we're going to have a brief introduction on, or overview of how you, if you and your programs want to request support for SBC, how you can go about that. Okay, so what is the Tech Rrt? So I'm going to give you a brief overview of what we do. So the Tech Rrt is a technical rapid response mechanism that supports improved nutrition programming through deploying advisors, remote support, and capacity strengthening initiatives. So at the moment, the majority of our work is providing remote support given the COVID pandemic. But our usual business is deploying advisors to nutrition emergencies to improve the technical capacity of them. And we're a consortium, the project, of 4 agencies, IMC, Action Against Hunger Canada and USA, and Save the Children UK. And we're very lucky to have the support of 4 different donors, USAID, Irish Aid, CEDA, and Save the Children kindly support us with some of their own funds. And we work very closely with the Global Nutrition Cluster, identifying technical gaps at country level, and also with UNICEF. And the Tech Rrt is playing a key role in the development and ultimately the implementation of the Global Technical Assistance Mechanism for Nutrition, or GTAM. So the goal of the Tech Rrt is to improve and strengthen the technical quality of programs and assessments for improved nutrition outcomes of affected populations in emergencies and protracted crises situations. So the Tech Rrt, who are the Tech Rrt? So we have a coordination team. There is 3 of us, a program director, Andy Kendall, a deputy program director, myself, and a program officer who we are currently recruiting. And we are responsible for the day-to-day managing of the Tech Rrt and the coordination of our 4 advisors. So, and those advisors cover 4 different technical areas. We have one advisor, Alexa Humphreys, who supports surveys and assessment. We have a second advisor, Martha Nakakande, who is our CMAM, Community-Based Management of Acute Malnutrition Specialist. And we also have an infant and young child feeding and emergency specialist, Brooke Bauer. And finally, and on the call today, we have our social behavior change advisor, Sona Sharma. So those 4 are permanent standby staff who are available to support emergencies in nutrition when requests come. But we also often have more requests than those 4 can fulfill. So we have the flexibility to find others if necessary. And all of our deployments are reviewed and endorsed by our deployment steering committee, which consists of the Tech Rrt members, consortium members, and UNICEF and the GNC. And then finally, just a quick overview of what the Tech Rrt has done. So we've been in place since 2015 and have responded to 61 different deployments in 22 different countries. And the bar chart there, you can see the share of the technical areas that we support, the most frequent being IYCFE. Okay, so enough from me. That's about the Tech Rrt. At the end, we're going to have a little bit more detail on how you can request the support for Tech Rrt. But before that, we're going to hear much more from Sona, Ravi, and Mohini about SBC specifically. Okay, over to you, Sona.
Thank you, Ben. Good evening, good afternoon, good morning to everyone, depending on which part of the country you come from, and you're joining in with us. So thank you for joining in on this webinar on social and behavior change for nutrition and health outcomes. I'm sure you will agree that especially at times like the one that we're going through right now, social and behavior change plays a very critical role. So while we're not going to talk about SBC for COVID-19 specifically, in our presentations, the same basic principles and approaches apply to tackling the current situation as well. I am going to turn off my video so that the focus is on the presentation, and we'll probably see you later again. So my presentation will cover 3 major aspects of social and behavior change, as Ben mentioned. The first, I will delve a little bit into understanding human behavior and the importance of the social context. Next, I'll cover the role of SBC in emergencies, and the third and a major part of the presentation is on the process and the approaches for planning SBC interventions. As you will see, this is a very broad overview of SBC as an introduction to the concepts and approaches. It does end with 2 very specific case studies, and we're fortunate to have the 2 presenters with us here today. But before I start, I'd like to mention that a webinar like this has some limitations, and one of them is that I don't know my audience. I don't know you too well. So your level of understanding and experience with SBC may vary, and I might talk about some very basic concepts that some or many of you already know about. So please bear with me. And in case the things that I say are not clear to you, please ask in the chat box, and I will try to make it clearer during the Q&A session. Can we go on to the next slide, Ben? So let's start with the definition of human behavior. It can be defined in many ways, and the definition that we've chosen for this presentation is that it's a person's observable patterns of action in relation to the environment that produce measurable results, and these results could be positive or negative. In health and nutrition, some of the examples of critical behaviors that are of concern to us are around hygiene, such as hand washing, which is even more critical now. Feeding behaviors for adolescents, mothers, and children, and treatment-seeking behaviors for individuals, for themselves and their families. Each of the critical behaviors mentioned on the slide here, hand washing, exclusive breastfeeding for the first 6 months, complementary feeding, and treatment seeking, have multiple associated behaviors that have an impact on health and nutrition. For instance, complementary feeding is not just about initiating it at the right time, but also about feeding in adequate quantity, frequency, and quality, which changes as the child grows older. So that's just a little bit about the definition of human behavior and some critical behaviors that are of concern for us in health and nutrition. Can we go to the next slide? So in order to be able to stimulate positive change in the behaviors linked to health and nutrition, we must first learn from behavioral sciences about how and what influences our decision making. We know that each of us has developed, each of us has developed our own rules of thumb for what we will or will not do. And also that we are constantly, subconsciously or unconsciously, doing our mental accounting of weighing the pros and cons of the benefits and losses of doing certain things or not doing certain things. Also that our decisions are influenced by all of this, the mental accounting, the rules of thumb, as well as our past experiences. And what we often forget and we need to remember is that we as humans have very limited attention span. But I think more important than all this is also the fact that the behavioral economics research by Professor Daniel Kahneman also tells us that our brain has two systems of functioning. The system one of the brain functioning is fast, it's automatic, it's emotional, it's unconscious, it's instinctive and reactive. This system is engaged when we hear a known language or even something as simple as an addition of 2 + 2. I'm sure nobody here would think of the result as being 1 or 2. We do think about, we automatically think, okay, 2 + 2 is 4. Or if we want to complete the phrase war and, the next word after war and comes automatically to most of us. The other example would be of an experienced driver when he drives to work, he or she drives to work in the morning. The complex act of shifting gears is just as natural as walking to them. So this is when the system one of the brain is engaged. The system two, on the other hand, is the slow thinking, effortful, logical, more controlled, conscious, a slower, deliberate way of thinking, which does the planning and the problem solving. This system is engaged when we first learn a language or a skill, because it requires a conscious effort to learn and acquire the new skill. But the important point here to remember is that around 90% of the time, our decisions and hence the behaviors that we make, that we do because of those decisions, are made by system one, which is automatic and instinctive. So the need is for us to then use a combination of subtle influences or nudges that guide the fast brain into making the preferred decision automatically, and also at the same time engage with the slow thinking analytical brain to direct it towards better calculated decisions. So that's just a little bit about how we think and make decisions, but there are further complications. Behavior is a complex phenomenon that is influenced by factors that are within the individual and beyond. The socio-ecological model that you can see on the screen right now recognizes 4 levels of influence that interact to affect behavior: the individual level, the family and peer networks, the community, and the social and structural levels. So, for example, whether a mother will exclusively breastfeed her child or not is dependent a lot on her individual attitude towards breastfeeding, her knowledge of the benefits, her confidence in being able to breastfeed her child regularly, and other aspects of her individual beliefs. But it is also dependent on what she perceives her peers are doing, which we call descriptive norms. What her family members and peers believe. For example, there is a strong belief among older women in many places that breast milk alone will not be enough for the child to grow well, or that in a hot climate, the newborn also needs water. So just giving them exclusive breastfeeding is not enough. So these beliefs of the family members and the peers also impact whether the woman will breastfeed her child exclusively or not. On the other hand, even the cultural and gender norms in her community would expect her to be obedient or to listen to the elders or the spouse in the family, who could be of a firm belief that breastfeeding is just not enough. I mean, exclusive breastfeeding is not enough. So it's not enough to address just the individual barriers to behavior change. And as we see, intervention, including the communication component, needs to assess and address barriers and enablers at all these levels: at the individual level, at the family and peer network level, at the community level, and at the broader social and structural level. Can we go to the next slide? So what is the role of SPC in emergencies? We all know during disease outbreaks and emergencies, there are specific actions that are required of affected communities for prevention, containment, and control of the outbreak. And we know that more than ever now. Communities need to be informed, motivated, and equipped to practice the necessary protective behaviors. And this can be achieved through effective SPC programming. Let's take the most pertinent example of the current COVID-19 pandemic. The first action by most technical and community-based organizations needs to be to provide clear, accurate, and relevant information in a timely manner to the communities. To do this, it is essential. Can you all hear me clearly? My internet shows it's unstable.
That's okay now, Sona, but you did go away for 1 second.
Okay, okay.
Unclear, but it's okay.
Okay, okay. So, so as I mentioned, the first action by the community, by the organizations, needs to be to provide clear, accurate, and relevant information in a timely manner to the communities. And to do this, it is essential to identify what are the barriers and enablers in the area that we're working in. So for example, if the people in our community have existing knowledge that hand washing with soap prevents diseases, or there's a proactive community leader in the community, these would be strong enablers that we should build upon, rather than only providing technical or information about what to do and what not to do. We need to start looking at the community and contextualizing our messages to the community based on the barriers and enablers. And also in such a situation, and I'm sure all of us realize that today about the COVID-19, that myths and misconceptions seem to multiply manifold during the emergencies. Some examples that I can mention are, people in rural areas believing that COVID is a disease for those coming from Europe, or that traditional medicines will keep COVID away and keep them safe, keep people safe, or even among health workers that spraying chemicals on people is required to disinfect them. Now, this, I'm sure a lot of you must have heard about this news from India. But and these kind of myths and misconceptions are not just disastrous, but also very dangerous. They need to be tackled at the earliest, and at the same time, we need to be able to build the trust of the community and ensure that there is no panic created. After the emergency is over, it is necessary to continue the communication, continue the intervention to ensure that people are able to recover from the crisis and rebuild their lives. This often includes counseling and mental health interventions, depending on the crisis levels. And for all this to happen systematically rather than as knee-jerk responses, it is essential to follow the process of developing an SBC strategy and plan in a systematic manner. The basic principles for and the process for developing social and behavior change interventions in emergencies remain the same as they are for other normal situations. But in emergencies, we basically need a faster pace, higher flexibility, and more robust systems to be able to assess and adapt to the changing situation. Can we go to the next slide? So as we've seen, behavior change is not a simple process, and promoting behavior change, while it's not rocket science, it is not easy either. So this slide just shows us some typical problems that the project staff may encounter in an intervention to promote hand washing. So you might, either in the middle of the program or towards the end of it, realize that people's knowledge had increased, but they didn't feel motivated to act. That we spent a lot of time on radio spots, but the target group didn't get to hear them because they didn't have radios. Or the hand washing practices improved at first, but then again, it was low at the end line. So there are a lot of these problems that people have faced. And to avoid these difficulties, it is essential to use a systematic and scientific approach to behavior change. We need to treat behavior change as a technical subject, using reliable tools and methods as part of a programmatic approach, just as we would do for any other intervention. We'll go next. So the next few slides talk about the process and the approaches to use for behavior for an SBC intervention. The process largely and very broadly can be described in about 5 steps, and I'm sure these 5 steps are not alien to any of us working in programs. To initiate the process, analyze, design, implement, and measure the intervention. And we will go into a little more detail on these steps, but the point I wanted to make here is that we do need to go through these stages sequentially, regardless of the approach and the theories of behavior change that we would like to apply in the intervention. Can we go next, please? So this is again the process, for convenience, I have put it in 4 stages rather than 5, where the implementation, monitoring, and evaluation has been put together. In the initiation step, we identify the problem or the challenge to be addressed through behavior change, and we'll go into a little more detail about this step. In the analysis step, we conduct formative research to understand the behaviors in question, who practices them, what and who influence their behavior, and the change in behavior, and the different options for how to achieve the required behavior change. This is then followed by the design stage, where we set the objectives for behavior change and build a strategy and plan for the intervention based on the analysis that we've done in the earlier stages. Then the intervention is carried out as planned, adjusted if necessary, and based on what we find in the monitoring, during the monitoring, we try and adjust, make changes accordingly, and then eventually measure its achievement. But I think that the one point I would like to make here is the fact that behavior change is a continuous process. It is not a one-time activity, so we don't go from step 1 to 5 and then stop there. The evaluation then feeds into the next stage of the intervention, and the same steps are followed in terms of the initiation, analysis, and design. Can we go next? So every stage has a number of specific steps to follow, but since we are conscious of the time and the fact that we have limited attention span, the next few slides will only highlight the essence or the things to be kept in mind for each stage. So at the initiation stage, it is important to be able to clearly determine the need for behavior change and which behaviors are we trying to promote. So while reviewing the behaviors that impact the project objectives, we will need to keep in mind certain conditions or facts that make behavior difficult to do. For example, 3 or 4 antenatal checkups involve multiple steps over the pregnancy period, starting with timely registration, going for a checkup on the scheduled date every trimester, and making sure that each antenatal checkup has all the 5 elements of checkup that are required. Or if the behavior is not a social norm, for example, if the intervention would like to increase male engagement in complementary feeding, but the norm is that it's a woman's job. So men playing an active role in child feeding is not the norm. So it would make it difficult to change. Behavior is also difficult when it requires complex skills such as recognizing diarrhea or managing it at home with ORS solution, continuing breastfeeding, even during diarrhea, etc. So if such behaviors are critical to achieving the project objectives, they also justify the need for a strong behavior change intervention. Yeah? So the initiation stage is about identifying these priority behaviors that need to be changed. Analysis is an important stage in behavior change process because the information collected in this stage will be used for the design, implementation, and monitoring of the intervention. So the quality of information will play a major role in determining the quality of your design and hence the success of your intervention. So the 2 recommended steps that are for this stage are to first conduct a literature review. To summarize what is already known and what are the gaps about the local context, the priority group, and its practices related to the behaviors to be promoted in the project. The next step is to choose the most appropriate method or a mix of methods for the additional research required. There are many different formative research methods available for assessing community context, behavioral factors, and complementary elements, and there is no correct method for all situations. Different approaches have been developed using different combinations of research methods, and the decision on which method would be suitable for a project would be based on the time available for the research, the organization's access to expertise required, the type of behavior that the intervention is focusing on, and the information gaps to be filled. And in all this, ethical considerations, of course, are an absolute necessity. Programs that we work on are mostly designed to improve the nutrition and well-being of populations that are at risk. That is to say, people who may be experiencing distress and disempowerment already. So it's even more imperative for us to adhere to ethical principles to achieve program goals. And this especially applies to the analysis stage, but is equally applicable to all stages of the behavior change intervention. Can we move next? And this slide is basically to give an example of how to choose the right method for additional research with the time available as the criteria. So if the time available is 1 to 2 weeks. Hello. Okay, so if the time available is 1 to 2 weeks or 1 to 2 days from time to time, we will need to do a quick review of the secondary data available, identify gaps, and conduct a small number of observations, key informant interviews, and focus group discussions, or maybe choose between key informant interviews and focus group discussions. But if we have a time of 2 to 6 weeks available for the formative research, 6 weeks is usually a good enough time to be able to do a fairly in-depth qualitative study Then there are more options available, and I have listed some of them here. The assisting behavior change, ABC research methods. There's the barrier analysis, the behavior-centered design, assess and build stages. The trials of improved practices, and SBC, the analyze the situation and identify and describe the audience, the step 1 and step 2 of the SBCC iKit. The links for these will be are all there at the end of the presentation, so you will be able to access these resources as well as per your need. And however, 6 to 12 weeks is a luxury that is often not available. But if we are fortunate enough to have this time available, a full range of methods can be used, depending, of course, on the need and the other criteria that we mentioned earlier. So social marketing formative research process and the full range of the assisting behavior change research methods can be used. We go next. This, I think, is one of the most critical aspects of the analysis stage, the second stage, which is while working in SBC, one is often asked, is it really necessary? And it spends we spend a lot of time on formative research, and very often we only reconfirm things that we already know. But I think it is critical to be able to understand the context much better. Even if there are only 1 or 2 small things, those are often things that are game-changing. So the formative research analysis must be able to give us answers to all these vital questions that will help us design the strategies for behavior change. It should help in prioritizing the behaviors, identifying the audience segments whose behaviors need to change, as well as the influencers who can influence these people who need to change the behaviors. It should be able to identify social norms that need a focus, and how to most effectively reach the identified audiences. What channels and tactics would be more effective. In the emergency context, in addition to all the questions to be answered by the analysis, it is also essential to continuously review the epidemiological information regarding the health issue linked to the emergency, and keep a track of the myths and misconceptions around it. Can we go next? So this is actually my last slide, but it will take a little time, because as you can see, there are a whole lot of different approaches, and these may not be the only ones. There could be more as well. We have selected some of them which have been have showed some evidence of success in health and nutrition interventions. So the design stage of the process is where you would try and identify what approach do we want to use. And all these approaches that are mentioned here have been tried and tested for a range of nutrition and health behaviors. Each approach has its strong points, and there are guides and manuals available online for most of these. So to give a very brief description of each approach, we have the time, right, Ben? How are we doing on the time?
Actually, we don't, Sona, I'm afraid.
Okay. Okay.
Your time is up exactly now, so you timed it very well.
Okay. Okay. So I think I'll just end there, saying that each of these are available online, and they have their strong points. And we are fortunate that 2 of the presenters here are going to share their experiences on 2 very different approaches that they've used. So with that, I will now hand over to Mr. Ravi Menon from GAIN to take us through the first case study.
Thank you very much, Sona. I'm very glad to be here to present our Baduta program in Indonesia. So as you can see, the Baduta program actually is an acronym for children under the age of 2. And we used the concept of healthy gossip for social behavior change intervention for nutrition. Next slide, please, Ben. Right, so a little bit about GAIN for those who do not know. So GAIN is a Swiss nonprofit foundation set up in 2002. What we do is, like any NGO, we raise funds from donors and we channel to nutrition programs in 12 countries. Our vision is a world without malnutrition, And our mission is to improve nutrition outcomes by increasing the consumption of nutritious and safe food for all people, especially the most vulnerable. Next, please. Right. I realize now there's a missing title on this chart. This is actually showing the situation of stunting in Indonesia in the year 2013. When now the present rate of stunting in Indonesia is actually down to 30%, 30.6%. But when we started the program back in, when we started the program in 2013, the rate was 36%. Today, in the last time the basic health research or the risk-DAS was done, it's come down to 30.6%, which is a fairly good decrease over the years. But this is the situation when we started the program in 2013. Next, please. Right. So Baduta 1 or 1.0 as we call it, actually it took 2 years to do the research and to do all the accompanying SPC materials that accompanied it. The actual implementation time was 2 years, from 2015 to 2017. Now, we were lucky that when we started designing the program in 2013, the Lancet series on maternal and child nutrition had just come out. And so we were able to actually, in this intervention, include both nutrition sensitive and nutrition specific interventions. So we actually did 4 things. Of course, we did a behavior change program for improving IYCF interventions. We also worked with Save the Children to Netherlands to strengthen the health services. We did a limited wash intervention, whereby we worked with a private company called Nazawa. Nazawa, they supply water filters, but we also got them to help to do hand washing with soap training at the community level. And fourthly, we worked with the Ministry of Health to promote the multiple micronutrient powder called Taburia, which is the government brand of M&P. So with these 4 interventions being done at the same time over 2 years with 4 different implementers, the aim was to reduce maternal and child malnutrition and micronutrient deficiencies. Please. So based on the formative research, which we actually worked with the London School of Hygiene and Tropical Medicine, who pioneered, who came up with the behavior-centered design, which Sona just mentioned some time back. So with them, we did extensive formative research. We actually had the luxury of 12 weeks because this is a planned intervention. It is not an emergency context. And we targeted 4 behaviors. The first was to reduce or stop giving, to stop giving formula, because breastfeeding alone is sufficient. The second was to give children a more diverse a plate of complementary food, because what was happening in East Java was that we found that mothers were essentially giving just white porridge with a little bit of green in it. So the idea was to give them a more colorful plate. The third behavior that we specifically wanted to target was to stop giving children unhealthy snacks, because the social norm in Indonesia is that children really should not make a noise. The moment they cried, the instinctive reaction of the mother or the grandmother or the caregiver was to feed the child something. And that something was more often than not a snack, which was usually something brought from the store, to some kind of a sweet thing or something very store-bought and absolutely zero nutritional value. And the fourth behavior was actually targeted to pregnant women, to ask them to add one portion of strengthening foods to their intake during their pregnancy. By this we specifically meant either an egg, some chicken liver, or a portion of fish. If you're wondering why the order is wrong, it should be pregnant women and then of course the children and breastfeedings, because we actually got additional funds to do the maternal intervention a year into the program. So that's why the order is slightly reversed. Next, please. So we actually followed a multi-channel SPCC approach using the London School's BCD design. We actually worked on 4 television advertisements using their theory of change, which relies quite largely on the use of emotion, because the theory there is emotion can actually trigger behavior change. So we followed that up with activation at the community level, or the community health posts. Now this activation again followed the same BCD principle to design a series of games. So they're called emo demos, or emotional demonstrations, which I will dwell on in the following slides. We combined the activation also with home visits, because the emo demos were held at the health outposts, but our facilitators actually went and visited mothers and fathers in their homes and also explained about these emo demos and what we are trying to do. Facebook is very, very popular in Indonesia, so we had a digital media campaign to support this intervention. And as I mentioned, we worked on health system strengthening through Save the Children. They worked on introducing the baby-friendly hospital initiative in the areas where we are working across the health centers. This was to complement, of course, the efforts that we were doing with the emo demos and the TVCs to increase breastfeeding and complementary feeding. And of course, last but not the least is the advocacy that we did. We did actually 4 years of advocacy, not just 2. Working with the government at the central level and the district level and the province level to make sure that regulations were changed or put into place to support all the work that we were doing, particularly regarding the laws regarding breastfeeding, and making sure that in the workplace situations, mothers had rooms for expressing breast milk and things like that. Okay, the next slide, please. Right. I think we're going to screen a TVC, if I'm not mistaken.
We are indeed. When I find it.
Right. So what we're going to show you here is a TVC that we developed based on the BCD theory. It's actually it shows the principles of BCD. It is subtitled and it's about 30 seconds. So I hope we'll be able to show this. Yeah. I can't get the volume. Right. So even though that didn't have volume, I guess it is subtitled. So I'm hoping that you were able to see it. What I hope you would have all noticed is that in 30 seconds, there was one really dramatic shot in that, which was the grandmother flicking the bottle of formula into the waste bin. Now, this was something which was huge because in Indonesia, mothers consider formula milk to be better than breast milk. So it's if you can't afford to give your child formula, you're not a good mom. That was the norm. So this very action of showing the grandmother flicking that into the dustbin, it just caused this huge concern and anger and confusion among the mothers, and that's exactly what we wanted. So the idea was to show that it actually is garbage, and that's what we intended to show. So and of course we had emo demos to accompany that. Can you go to the next slide, please, Ben? Right. So emo demos, as I mentioned, are emotional demonstrations. They're group games, and they operate by creating a moment of surprise, which heightens or changes associated with a particular behavior. And again, as I mentioned, it's based on the London School of Hygiene's behavior-centered design theory. Next slide, please. Right. So if we only tell people what to do, which is the normal way of instructing or giving posters or just a TVC, they only learn through one particular part of their brain. But what it leaves out are all the other ways of learning through sound, learning through touch, learning through seeing, habits, emotion, smell. We overlook all the other ways of teaching people. Now, emo demos combine all these various ways of touch points, and they help to which we associate with a desired behavior, or with an undesirable behavior. Next slide, please. So in this particular, so we really learned on the way marketing companies use emotion to influence behavior. This is an ad for Nissan, the Nissan Terrano. I think it's from India. Now, we all know cars get us from one place to the other. But if you look at this ad, what does it say? Command the road, all the attention. Next, can you click, please, Ben? Oh, okay, there's something you missed. Okay, well, essentially what that ad, can you go back one slide, please? That ad does not mention anything about the fact that the car gets you from A to B. What it does is associate your social status, associates owning the car with your social status and to be the center of attraction. Command the road, all the attention. That's what it does. It says nothing about moving from one place to the other. And we learned from that. Next slide, please. So I can't go into this, but these are various, we developed 12 games. So therefore we had 4 behaviors. So each behavior had roughly 3 games for them. They were done in the community health outposts where mothers bring their children once a month. So 12 games means once a month they could experience a different game throughout the whole year. We have a whole bunch of resources that we can share later. Next slide. So the evidence that this works. Now I'm sorry, these are really busy slides, but we did do a randomized control trial involving 3,000 women. This was independently evaluated by a consortium from the University of Sydney and some universities in Indonesia. So what we found over 2 years is that I've listed, actually there are 2 slides. So I'm just highlighting the significant changes that we found out. So significant means anything more than 5 basis points, of course, as you know that. So we found out there was significantly higher initiation of early breastfeeding. The really interesting thing is the middle slide. So what we found is that there was a 15% increase in exclusive breastfeeding among the women who actually experienced our intervention, including the emo demos. And again, lower use of pre-lactal foods. Next slide, please. Breastfeeding, the state of breastfeeding, the higher proportion of children consuming iron-rich foods at end line, and of course the dietary diversity. Next slide, please. So in conclusion, we did, of course, our spots were on national TV, and they had very good coverage, and they were very, mothers remembered them. Everybody remembered them. They all had elements of shock in them. The package significantly improved breastfeeding and complementary practices. It did not improve maternal intake of iron-rich foods, mainly because the time was too short. Dietary diversity improved. And based on this, we decided to scale up in Baduta 2.0, which is going on now from 2017 to 2020 in 5 additional districts. Next slide, please, Ben. So now we are in we have reached 1 million women in 11 districts. We have trained 11,000 health workers, and most importantly, this is paid for by the local governments. And to sustain this, we're doing this. This is part of the nutrition curricula in 20 universities. We've given away the entire methodology. That's it, I think. Thank you very much. If you have any questions, the email is there at the bottom, info@gainhealth.org. Thank you very much.
Great. Well, thank you very much, Ravi. We're going to go straight on to Mohini. Mohini, are you there?
Yes, Ben. Can you hear me okay?
I can hear you loud and clear.
Okay, perfect. Thank you so much. And thank you for the opportunity to share with you another approach to behavior change, which is called nudges, and you heard about it from Sona. And essentially, we called it behavior change without behavior change education in a study that we implemented in Bangladesh. And I'll also share briefly with you what we've done since that study in another project in Thailand. Next slide. And Ben, you'd need to turn my video on. I'm unable to do that. So first, I'd just like to go over what are nudges before I go into the research study in Bangladesh, where the primary behavior we were looking at was hand washing with soap after toilet use. And then I'll speak briefly about this project in Thailand and share some pictures with you from there. Next slide. So nudges are not new. They've been widely used by social scientists to influence behaviors and as environmental cues for triggering behavioral outcomes. They don't provide any knowledge or incentives or alter decision-making processes. As you heard earlier in the presentation from Ravi, it's a very different approach where we're looking at changing the context or the environment in which behaviors occur and have that system one thinking kick in for the user, for the target individual or group to behave in a certain way positively or to avoid certain behaviors. And here are a couple of examples which many of you may have seen. One is of a urinal where there's a black fly drawn in the urinal, and that's the nudge for ensuring hygienic use of the urinal. So there's no spillage of urine, so urinating inside the urinal. And there you see on the right, neon steps leading to a waste bin to influence use of the bin for throwing garbage. So this kind of choice architecture, next slide, provides positive reinforcement and indirect suggestions to influence behavior change. And this was popularized by Professor Richard Thaler, who is a Nobel laureate, and Cass Sunstein in their book called The Nudge, which I'd strongly recommend you read if you'd like to know more about how nudges have been used in various fields, especially in behavioral economics. And it follows 4 simple principles called the EAST principles, which is keeping it very easy. So not having too many words or too much noise or stimulus around your main message, that the message is lost. It's something that even a child should be able to understand. Second, the nudge should be attractive. It should be appealing to get someone's attention. So bold colors, designs make for good nudges and catch people's attention. Thirdly, it should be social in that it encourages certain behaviors or prevents certain behaviors because others would do it or not do it as a rule. Words like you should eat a balanced diet, for example, may not work, but a simple food plate graphic can be enough of a reminder for children when they're serving themselves food at a school cafeteria on the portions they should be taking. Or it could be just the plate in itself having those separations for them to serve themselves foods from different food groups. And lastly, it should be timely. So we want to encourage behaviors when it's most likely to be disrupted due to something else. So an hand washing nudge in the case of hand washing after toilet use should be very close to the toilet cubicle so that children don't forget to wash their hands with soap and just run out and play, for example. Next slide. So one of the first research studies on nudges in the wash sector, and this is a nutrition sensitive intervention, so it is very relevant, I think, to this audience, was this cluster randomized trial that was done in Bangladesh, which compared nudges to a high-intensity hygiene promotion intervention. It was done in collaboration with the researchers at the London School of Hygiene and Tropical Medicine and the University of Oklahoma and the University of Buffalo, along with Save the Children. And before we embarked on this research study, we implemented a feasibility study to see the potential for nudges. Next slide. And I don't know if the animation is working here, but essentially we identified 2 schools in rural Bangladesh for the nudges. And these were schools that had not yet received the wash block intervention from the government. And wash blocks are essentially, as the name suggests, a place where you have a toilet and hand washing facility within a toilet block. And so for these schools that hadn't received that new intervention, there was no immediate nudge in the environment itself for hand washing. And so we developed the nudges in 2 stages where we, one, set up a hand washing infrastructure. And second, we added the nudges to encourage use of that facility. And you can see that there, the infrastructure was a raised platform with a tank of water and soap on the side where you see a handprint. And the nudges were these, initially we had designed them as footprints, but we changed them later to shoe prints because that's also important around the kind of behaviors we want to promote of use of footwear. And the handprints that you see on the hand washing station. And through structured observation, we measured the hand washing with soap behavior after toilet use. Next slide. And what we found was that at baseline, hand washing with soap was minimal. It was only 4% of the 921 children that we had observed. But once the hand washing station was introduced, we saw a jump in hand washing practices. When the nudges were subsequently introduced to the hand washing station and to the path, we saw a significant jump, 50% increase in hand washing with soap after toilet use. And that sustained itself and marginally increased over a 6-week period. Well, this was great. It did not provide us a reference, a comparison group to see how, to comment if these findings were rigorous. Also, because of the limited sample size, we could not generalize beyond the 2 schools. So we went in to design this randomized control trial, next slide, where we had 20 primary schools in a rural part of Bangladesh, receiving 1 of 4 interventions. There were 2 arms to the study. 10 schools received infrastructure improvements at the get-go, and 10 schools were controls for the infrastructure improvements because we wanted to compare just the simple act of including an infrastructure. We then introduced in each of these groups nudges and hand washing promotion interventions, either sequentially, which means one after the other, like you see in the infrastructure group, or as a combined intervention in the control group, nudges with infrastructure or hand washing promotion with infrastructure. And we collected data on these schools at different time points through the intervention over a 5-month period. So at baseline, when we first implemented the infrastructure improvements, 6 to 7 weeks after we had started the intervention, and then again at around 12 weeks, there was a period where schools were off due to the religious holiday of Ramadan. They were off for 4 weeks. And so after that break, again, we collected data when the interventions had been completed to look at sustainability of the behavior. Next slide. So how did we collect the behavior of hand washing with soap after toilet use? We used covert cameras in this case with a view of the school latrine and the hand washing station. Because these were hand washing stations outside the toilet block, we met with ethical norms of the research. And these were also supplemented with structured observations from time to time to see that the facilities were maintained and to use as a comparison with the video footage. A toileting event was described as when a child entered and exited the latrine and was in clear view of the camera. And hand washing with soap was defined as both hands being washed with soap. And we compared children in the infrastructure group versus the control group. We compared the hand washing behavior of children in the nudge group with the hand washing promotion group for all nudges versus all hand washing promotion. And we also compared the sequential with intervention with a combined intervention of infrastructure and hygiene promotion or nudges. What was the hygiene promotion intervention? The research team was completely oblivious to this. It was implemented by the Save the Children field coordinator. It was 4 weeks of intensive hygiene promotion through weekly sessions. So 4 in-depth sessions which covered everything from why you wash hands, how you wash hands, when are the critical times, and reinforcing that through practical demonstrations. And we analyzed the data both as proportions and as logistical regression models. What we found was overall, for all groups, there was an improvement in hand washing behaviors over the course of the 5 months. Next slide. And when we look at the hand washing promotion group with the nudges, we found that the nudges were as effective as a high intensity hand washing promotion intervention. And this sustained throughout the intervention period. Next slide. What is interesting to note was that when we compared nudges either done sequentially or with the infrastructure improvements, there weren't many changes, or there wasn't significant change in the behaviors of hand washing with soap among the 2 student groups. But when hand washing promotion was done sequentially or combined, there were big differences. And you see that red dotted line at the bottom of the graph being that period when, being the group that received the hand washing promotion after the infrastructure intervention. Next slide. These are just some figures that you can look at more closely later, which talk about the statistical significance around the differences we saw in sequential versus combined interventions. Next slide. So in conclusion, what we found was that nudges worked as well as high intensity hand washing promotion interventions. They were sustained over a long period of time. They were also easier to implement just because it required less training of hygiene promoters, fewer challenges with scheduling with the school calendar, and also in terms of ensuring consistent delivery, we were able to ensure the quality of the intervention across schools more easily in a nudge as opposed to hygiene promotion. And because this was a research study, the costs were pretty much similar. It was about $1,200 US for 10 schools in both cases. And we did use pre-existing hygiene promotion curricula, so that did account for the low cost of the hygiene promotion intervention. And then there are more things to test, and there have been studies that have come out since looking at different aspects of using nudges for different contexts in emergencies, for example, for different age groups. Perhaps it works better with certain age groups, and looking at also the costs and the processes involved in nudges. So learning from this study, next slide.
Great. Mohini, can I
Yes.
suggest that we move on to the Q&A? Please?
Sure. Yes.
Is that okay?
That's fine. Sure, Ben.
Thank you very much. But you did touch upon something at the end there, that we've had 2 questions about nudges in emergencies. So we will be coming back to you. I'll give your vocal cords a rest for the moment, but we'll come back to that one. So thank you very much, Mohini and Ravi, for your case studies. It was an excellent way to really bring a light on some of the theoretical outlines that Sona went through, and some of those many variety of SBC approaches that she identified. So thank you to everybody who has posed a question in the chat box. We're now going to have a go at those. And I am going to select a few. And please do, as we discuss these questions, please feel free to add more if any come to mind. But for the moment, we will. Ravi, I'm gonna, if you don't mind, start with you. We had a few questions, but I'm going to highlight one that I don't mean to start with one of, I think looks like the hardest, but I'm going to. Somebody, I do apologize, I haven't noted down the names, but somebody asked a question about how long did it take to change the mind of the grandmothers?
Right. So as I mentioned, our program has, it revolves around activation at the community health centers. These are the growth monitoring visits that mothers and caregivers bring their kids to once a month. So the question, I think, talked about grandmothers. Now this is correct, because in many cases, in one of the areas where we had the project, it was actually an industrial area. So a lot of the mothers were working, but the grandmothers were looking after the kids. So they were the caregivers, and they would bring the child to the growth monitoring community health outpost once a month. And as I mentioned, we had 12 emo demos spread out over 12 months. But anything to do around the feeding practices, we had about three particular 3 or 4 different games or emo demos. So that was the time period. That's all it took. In fact, some of the behaviors, even with them attending twice, the kind of emotions that it triggered were sufficiently shocking or sufficiently thought-provoking that they are made them feel so disgusted, so to speak, that they changed. And they're designed to be played in a community setting. It reinforces or changes a social norm. So yeah, if you were lucky, if the mother or grandmother was sufficiently shocked or happy or disgusted or whatever, she changed pretty quickly.
Okay, thank you, Ravi. And another one for you, I believe this one, if I remember correctly, came from Mohini. Is the BCD approach better for certain ages, and would it be recommended for younger children?
I didn't quite, actually, I didn't quite follow this because see, when we designed our interventions for around IYCF, MIYC, and including maternal, we wanted the mothers and caregivers to change the way they fed their kids. So these are kids under the age of 2, so or maybe under the age of 5. So really, I mean, it was targeted to the caregivers and the pregnant mothers. Can the BCD approaches be recommended for young children? I'm guessing you mean 7 to 10, perhaps. I'm not sure. I really
Yes.
wouldn't know.
Okay, great. All right, Mohini, well, we're going to come back to you now with that subject that I mentioned earlier. So nudges and emergencies. So firstly, are nudges, what kind of nudges can be used in emergencies or have been used in emergencies? So that's one aspect of the question. And one is maybe broader than nudges, but maybe you can answer it, and then Ravi, if he wishes, is what behavior change approaches, and maybe Sona, sorry, I shouldn't forget about you, Sona, what behavior change approaches can be used in emergency contexts, very much thinking about the shorter timeframes that we're dealing with, that are constrained by funding cycles, for example. That came from an anonymous person and also Andy Kendall.
Thank you. Thank you for that question, Andy. And I think Caroline responded already, my colleague who will be speaking tomorrow, that you can apply nudges to an emergency context. The slide that I didn't show you was around what are the things to consider when you're developing nudges. And that's something important to take into account when you're putting together nudges for an emergency context. And it depends really on what kind of emergency. If you're looking at a camp setting, how easy is it to make a nudge that will sustain, so it doesn't get wiped out or doesn't get damaged, or needs to be is expensive given the context. So there are a few questions that you need to ask yourselves in an emergency context before you design the nudge. It doesn't need to be a painted footpath. It could be a mirror. It could be something else. But absolutely, you could apply it in a research setting. And what could you use? You could use behaviors like the one that I talked about around hand washing with soap after toilet use. Very critical to avoid infectious diseases, outbreak of cholera or other diarrheal diseases. And then there are nudges that you could provide for food rations, for example, for meals. So it really depends on what behavior you want to promote.
Sona, are you there? Do you have anything to add on the behavior change approaches in emergency context specifically?
Yes, I'm here. So I think, as I mentioned earlier, it's probably not a question of which particular approach is suitable to or not suitable for emergencies. All the approaches can be used for emergencies. That the critical part here would be to make sure that we try and do all the steps within the limited time frame. So, for instance, even BCD, the behavior-centered design, can take about 4 to 6 weeks. So you can do a formative within a week. You can design it within 1 week and get it rolled out in the 3rd week also. So it's a question of making sure that the steps are done much more quickly. It's the faster pace of designing and implementing it. It's not really a question of whether a particular approach would not be suitable for emergency contexts.
Okay, great. Thank you. What else did we have? Yes. Yes. This is what I wanted to ask. Again, apologies. This came from one participant specifically around breastfeeding promotion. It came during your presentation, Sona, but it's open to anybody. Breastfeeding promotion. How can we measure the performance of breastfeeding promotion?
So there are, again, it really depends. Should I take Mohini, did you want to answer first?
No, please go ahead, Sona.
Okay. So I think it really depends on the context and your area of operation, because if you use something like trials of improved practices, that is something that can be measured on an ongoing basis. If you have very strong monitoring mechanisms and tools, that can be measured on an ongoing basis as well. So in fact, some interventions also use the monitoring tools as inspiration for other mothers to start to start exclusively breastfeeding. So it really depends on your context and the area of operation and the kind of approach that you're using. But mostly, good monitoring tools should be able to capture the progress as well. Do you want to add anything, Mohini?
No, I think that's right. It really depends on the context and the barriers to breastfeeding before you design your intervention. Also the age at which you're specifically targeting mothers.
Great. All right. Well, I'm going to go back to Ravi. I have a question for you. And after that, I'll have another one coming back to you, Mohini.
Sure.
Ravi, the question for you is, when it comes to the emo-demo approaches, is there a risk of rejecting the objective of the emo-demo if they're found to be too emotional?
Well, that was the whole point, actually, because we really wanted to provoke strong emotions. It was very deliberate. I mean, each of the ads have an element of shock or surprise, and every single emo-demo elicits a particular kind of emotion. And they're usually very strong. Mothers sometimes even cry. Sometimes they're disgusted. Sometimes they're angry. And that is the whole point of it, because we really wanted to stop them from doing what they always do. So the idea was to do something to cause enough of an emotion that they stop. They stop and they reflect, and then a new behavior is introduced with a better emotion. So it's the idea of I think the question was, would the emotion be so strong that they would reject the message? Well, they certainly would. It would cause them to question what they were doing all this time before, and that exactly is the intention. Do they actually practice or not? Because they're designed as a social behavior. We're trying to change a social norm, because you see, the problem we were facing in Indonesia was that formula milk was considered to be the best thing to do. I mean, if you didn't give formula, you were a bad mother. So we had to change the societal norm around giving formula milk, and for that everybody had to believe that giving formula milk was bad. So you're changing a social norm. So it's the use of emotions was very deliberately used. And did they reject it? Yes, I think a lot of them, especially the grandmothers, questioned it. The younger mothers, first-time mothers, not so much. I mean, I think first-time mothers are very susceptible for new information, and in any case, they're much more clued into to Facebook and WhatsApp and other forms of information that they're, yeah. But the grandmothers, yeah, they were the ones who actually were very shocked, but they changed.
Great. Thanks to Tomomi Kitamura for that question. Mohini, I have another question for you, and it's about identification of nudges. You've mentioned a number of different types of nudges, and the question was about how do you identify them on the assumption that nudges need to be context specific. Is that correct?
Correct. So the process that we've used in a subsequent project in Thailand and elsewhere, we're also looking at it, is to have the opportunity for the important, our target group to weigh in on what are the nudges that would potentially work in a given context. What are the behaviors, first of all, they think that need to be nudged, and then come up jointly with a small group as part of our formative research to develop a context-specific nudge. So, for example, in the Thailand example, kids love the idea of having painting their nudges on the ground for promoting physical activity. So they had identified physical activity as an important behavior to promote because of the obesity issue that we were seeing in the school population. And they participated in creating those nudges and so that's what you see over there in the picture. As opposed to having a playground or another kind of nudge for promoting physical activity. Does that answer the question, Ben?
I think, yeah, I think so. That's great. Something that came to me was, I wonder if that you've mentioned a few nudges that are my limited understanding of nudges. I was aware of, like the mirror, for example, for promoting hand washing, or the footprints for promoting hand washing. But I wonder if there was any sort of catalogue of nudges anywhere that an emergency program, for example, could draw upon for inspiration.
I'm so glad you asked that question, because we have developed a catalog of nudges along with the nudge guidelines, and that's something that's come out of this project. So we'd be happy to share that with you and the rest of the community, that you could use for all of the key behaviors around nutrition and WASH. And again, the more nudges you apply and you want to share that, do share that with the Tech RRT community, and we'd love to incorporate this into a living catalog of nudges centered around key behaviors.
Great, thank you, Mohini. We've had one last question just in from Emily Hirata. Thank you, Emily. And this is for Ravi. So I'm going to go straight away. Oh, Ravi has already answered it. Okay, Ravi, maybe you can explain verbally.
Yes, I mean, the idea was that I think the question is, can this stigmatize mothers who cannot breastfeed? Well, the thing is, we always make sure there is one trained health worker or a midwife in the community health outposts, and the health workers or the volunteers are specifically told not to answer any questions, medical questions regarding this, and to refer it back up to the midwife or to the doctor. And they're very clear. I mean, they usually, if they're signed on to the 10 stress, the baby friendly hospital initiative, they've already been trained, and they know that, yes, of course you can give formula if the mother is not able to express breast milk, if she's got a medical problem, then yes, that's the right time to actually give it. Otherwise, they really encourage mothers to breastfeed. So no, the idea is not to stigmatize anybody, but to show that there's a difference between giving it because you think it's the right thing to do and not being able to.
Great. Well, thank you very much, Ravi, Mohini, and Sona, for those responses. And thank you to everyone for your questions. So we have 3 minutes left, and we're going to very quickly, Sona, can we do this in 2 minutes, 1 minute each? Go over the kind of support that might be available from the Tech RRT in terms of SPC. Sona is going to deal with that. And then I'm going to just very quickly tell you how you can request that support. And then we'll have 1 minute to close with some very important final details. So please do stay with us. We will finish on time.
Sure. Okay, thanks, Ben. I think this again is one of the busy slides, but you can see that there's a whole range of support that the Tech RRT we can provide from Tech RRT. Which ranges from assessing the SBC implementation to technical training, and operational support for IYCFE, sanitation and hygiene, and health and nutrition interventions. It does include providing support in the entire process of planning, implementation, monitoring, and evaluation, or even specific parts of these of the process that require support. We will also be happy to provide coordination support for social and behavior change to in-country partners, to the nutrition and WASH clusters, or the technical working groups. The support can be provided both remotely or in-country support as a deployment of 6 to 8 weeks, but that would of course be post once the travel bans are removed.
Great.
So,
Thanks, Sona.
We'll move to the next.
Yes, and as I'm going to say at the end, you can get in touch with us, myself or Sona, at any moment, and we can give you much more detail about what Sona has just outlined. And I'm just going to tell you who can request and how to request and how much does it cost. Who can request any, we solicit requests from any agency, national or international, or other stakeholders with a nutrition technical need. That could be a nutrition cluster or sector group. And we also strongly encourage applications from or requests from national organizations. And our focus is nutrition, but that doesn't necessarily mean we only focus on nutrition organizations. So you may be a WASH focused organization, but with nutrition outcomes as an objective, they would still, that kind of organization would still be very much able to get our support. How do you request support? It's very easy. You just get in touch with us. I will give you our contact details at the end, and we take you through the process, developing a terms of reference, finding the funding, and lots of other details. And how much does it cost? Well, there are cost sharing options available. We have Tech Rrt grants, but we also try to identify those requesters where there is funding available in country. And there's lots of things which determine how much these remote or deployment support would cost. And so 6 weeks in-country support, anything between 25 and 50,000 USD, and 2 weeks remote support, anything between 5 and 9,000 USD. And those 2 weeks and 6 weeks are just examples, and any support that we develop is very much context specific, and the modality as well as the length as well. So we've already 1 minute over, so we should close. I want to thank all of our presenters very much for joining us today. And I would really, and also to all our participants, and we would really appreciate it if you could take the time to fill out our Survey Monkey. I will, in one moment, copy and paste that link into the chat box, so you can do it straight away, and it will take you an average of 6 minutes. And I'd also like to just raise that there's been lots of requests for resources and manuals and guidelines and the project specific resources as well that Ravi and Mohini mentioned. We will, along with the webinar recording and the slides, publish what we can on our website. So please do look out for those in the resource section of the Tech Rrt website. And finally, tomorrow we will be doing a rerun of this webinar. Obviously the question and answer may be different, in French. So if any of your Francophone colleagues who are not here today would like to join, then please send them our way. So with that, I wish you all a good evening, good afternoon, or good morning. And thank you again to all our presenters and everyone for coming and submitting your questions and taking the time to be with us. Okay, thank you
very much.
Bye-bye.
Bye.
Bye-bye.
Thanks, Ben. Thanks, Sona.
Thank you.
Thank you, everyone. Bye-bye.
Bye.
Thank you. Bye.
Bye. Thank you.
Thank you. Bye.